Hello people, in this video we want to look at tonometry. You're measuring something. What? Tonometry. You're measuring some tone, hypotony, hypertony of what? Of the eye. Whether the eye is hypertony or hypotony. So what are they trying to measure? They are measuring the intraocular pressure. So what is intraocular pressure? It is the fluid pressure inside the eye. So you have this aqueous humor here, right? In your posterior chamber and your anterior chamber, that is posterior is behind your iris. Here and here, you have this aqueous humor. So basically, it will measure, the intraocular pressure is the measure of this fluid pressure. Okay. So what is intraocular pressure? It is the measure of this fluid pressure in the eye. How will you measure it? By tonometry. Tonometry is measuring intraocular pressure. Why is it important? Because if intraocular pressure is high, it can lead to glaucoma. It can lead to, what is glaucoma? The damage of your optic nerve and visual field defect, possibly because of a raised intraocular pressure. So that is why you should measure intraocular pressure. Now how will you measure intraocular pressure, guys? Somebody is there in front of you and you have to measure this intraocular pressure. There are many ways, guys. So basically you have a subjective method or you can use an instrument. If you use instrument, there are some instruments like, see, instruments, when you come, you have indentation instruments and applanation instruments. Indentation actually measures the depth, okay, and applanation measures the force required. We'll tell you all that, but anyways, understand what is this? There is, how will you measure intraocular pressure? By subjective method you can do, or you can use an instrument called as tonometer. In tonometer, you have so many types. You have the indentation tonometer and you have the applanation tonometer. In indentation, you will be measuring the depth. Example is a Schiotz Tonometer. And in Applanation Tonometer, you will be measuring what? The force required, right? And that you have Goldmann's Applanation Tonometer and so many other types of tonometers like Perkin's, Pneumatic Tonometer, Pulsar Tonometer, Tono-Pen, etc. So let us look at one by one. Subjective tonometry is a subjective method. How will you measure the intraocular pressure? Digitally. Digitally means using your fingers. So you will just touch here where two fingers placed a short distance from one another above the superior tarsal plate. So this is where you will keep your two fingers above the superior tarsal plate, short distance from one another. You will test for fluctuation. So if it's stony hard, you know what it is. It could be absolute glaucoma, right? What do you think, guys? Am I saying it correctly? Correct, right? Okay. So testing for fluctuation, this is digital method. I think you need a lot of experience to know what is hard and what is soft, right? Yeah. Okay. Then indentation tonometer, guys. Indentation tonometer, you will be measuring what? The depth. Okay. So there will be a plunger which will indent a soft eye. So soft eye means it will go more inside, right? So depth is what you are looking for. The indentation tonometer currently which is in use is the Schiotz Tonometer. How do you say this? Schiotz? That's right, guys. Schiotz Tonometer. Schiotz. So basically it is so simple, reliable, low price, accurate, etc. So this is your Schiotz Tonometer. It comes with a 5.5 gram weight, which is permanently fixed. 5.5 gram weight is permanently fixed. You can increase it by 7.5 and 10 gram also. So here I think they have written 7.5. Can you see here? 7.5 and this looks to be 10. So this is your Schiotz Tonometer. Basically what is this? Indentation tonometer, right? Okay. So there will be a handle for holding the instrument. See, this was what will touch the eye, okay? This part will touch the eye. So you will have a handle to hold the instrument in vertical position. Footplate rests on the cornea. So footplate, this is a footplate, it rests on the cornea. Plunger which will move freely within a shaft in the footplate. Bent lever whose short arm rests on the upper end of the plunger, and long arm, there's a short arm, long arm. So the long arm which acts as a pointer needle, okay? The degree to which the plunger intends the cornea is indicated by the movement. So how much this plunger goes in, that much is indicated by this. What is this, guys? Focus. What is this? They said it is something pointer. So the indicator, the pointer will show how much the plunger has plunged. Okay. So that's what will tell you the depth. So look at this. This is a Schiotz tonometer. How they are using. Before using Schiotz tonometer, test it on a flat surface to ensure smooth motion of the device. So on a flat surface, you will check whether it's plunging and that the zero line is achieved, right? Then this is how they are doing. They will apply lid separation Apply lid separation pressure to the bony orbital rims. An assistant may separate the lids while you concentrate on the proper placement of the tonometer. How's it going, people? Is it too much to understand? Are you understanding the procedure of Schiotz tonometer? Yeah, so hold the tonometer vertically during use and rest your hand against the patient's facial bones. So your hand is against the facial bone, okay? After anesthetic drops are instilled, the patient will not experience any pain from this procedure. So you have to give anesthetic drops here before doing this. It's important to have a relaxed patient because squinting and blepharospasm may interfere with the reading. Gloves should be worn, which they have not worn here. So you have to do this procedure under an anesthetic. I'm thinking local anesthetic, right? So what reading will you get? So what is the normal IOP? You have seen that in our glaucoma video, right? Have you? Yeah. So normal average is around 10 millimeter of mercury. So our normal will be around 10 to 21, right? So what will be normal IOP? 10 to 21 millimeter of mercury, isn't it? And if it is greater than 22, it can become raised intraocular pressure. The rate of aqueous production is 2.3 microliter per minute. You have to remember this. The average IOP is around 16, okay? 10 to 21. Above 22, they are calling it as raised intraocular pressure. So people, what do you think the reading will be if it is normal? Wait, let us try to understand this here. This is the scale reading. This is the weight. In this weight, in this weight, in this weight. Let's go with this millimeter of mercury. From 10 to 21, it's normal, they said, right? So if you are getting a reading of 8 to 4, 4 to 8, it's fine. So a reading of 4 to 8 is fine, looks like. Okay. So if it is less than that, actually if the reading is less, then it means it did not plunge. So the depth, it did not go. So the intraocular pressure is high. So if the reading is less, the intraocular pressure is more. If the reading is less on your tonometer scale, it means your intraocular pressure is more, guys. Focus here. Did you understand? See, they are saying here, you use greater than 5. Accuracy is more dependable with scale readings greater than 5. So did we have greater than 5? No, here 2.5 is the reading. So if the scale reading is less than 5, it is better to use the next highest weight, which will give a reading of 5 or more. So they're saying don't go with something like this, go with some reading which is 5 or more. So it is better to use this 7.5 or 10 7.5 gram or 10 gram. Okay. So let's say for 7.5 gram, if you want normal IOP will be this, right? So again, if you are getting lesser reading, it means raised intraocular pressure. Okay. Anyways, guys, I think so much details you don't need. I've just told you. So how do you do Schiotz tonometry, guys? You have to wear gloves, you have to give anesthetic, everything you will do, right? Let's see what they are saying here. Can you see the plunger here? Right? And that will affect the reading, looks like, right? That will affect the reading. Okay. In technique, really not much they're saying, guys. You have to sterilize this tonometer, right? The Schiotz tonometer, use alcohol or acetone or heat it and you will be able to sterilize it. You will anesthetize the cornea with the topical xylocaine. You will make the patient sleep on the couch and then you will, they told you, right? Separate the eyelids, put your hand on the facial bone, make a person to do this so that you can focus on the job. You can have an assistant. Then you take the reading. If the reading is small, put some weights. Then you use this conversion table and find the value. Okay. So what are the advantages of Schiotz tonometer? It is cheap, handy and easy to use. You don't need any current or you don't need to buy some big digital equipment. This is a manual, mechanical way of doing it. Very good, right? Main disadvantage is that it gives false reading when used in eye with abnormal scleral rigidity. So if there's abnormal scleral rigidity, it will give false reading. Whoa. False low levels are obtained when there is low scleral rigidity. So if there is low scleral rigidity, false low levels you will get. And that means to say if there's high scleral rigidity, you will get high readings, is it? As seen in myopes and following ocular surgery. So let's say in myopes, what will happen? The eye will be really big. So there will be what? Scleral rigidity. So they are saying there will be low scleral rigidity, is it? In myopes, in high myopes, low scleral rigidity. So you will get low reading of IOP, it seems. Did it make any sense to you guys? But it can give you false reading, okay, in some cases. That's all I can understand. Okay, now let us go to Applanation Tonometer. Guys, what are we done with? We are done with two things. We are done with subjective one, right? And in the instrument one, we have finished the indentation one, which measures the depth and all. Now we are going to applanation. This is going to measure the force that is required to flatten the cornea with pressure. Okay, so Applanation Tonometer, this word applanation is usually referring to tonometry only. Have you seen this applanation word anywhere else? Okay, let us know if you have heard, okay. So basically this was a technique introduced by Goldmann in 1954. So this is based on some Iimbert-Fick law. It states that the pressure inside the sphere is equal to the force required to flatten the surface. So cute. So there is a ball, is a sphere. Inside there is some pressure. Now the force that is required to flatten the surface is proportional, or it is equal to the pressure inside. The force that is required to flatten the surface is equal to the pressure that is there inside. Would you say equal or proportional? So yes, here pressure is force by area. This is correct. But why are they using W here? Because work is force into displacement. So I'm not sure about this. We'll just keep it as force. But remember that work is equal to force into displacement. So you need to just check on this, okay? What is actually the correct one? Then coming to Goldmann Applanation Tonometry, just look at the image here, guys. So this is the biprism. It has two prisms, looks like, and this is how you will observe. This is the housing for the tonometer, and here you have some adjustment knob. So when you zoom this area, here they are showing some meniscus or something, okay? So this shows the meniscus, tear film meniscus created by contact of biprism and cornea. So you have the biprism. Here you have the cornea. So there's a meniscus of the, in between these two, you have the meniscus of the tear film. Wow. Now coming to this one on this side, intraocular tonometry with Goldmann Applanation Tonometer. Here they are showing you a truncated cone. A truncated cone is applied on the eye after installation of fluorescein. Oh, here they're using fluorescein, is it? And with violet illumination. So here you need fluorescein, I didn't know, okay. The size of the flattened ocular surface seen by the examiner. This is the flattened surface seen by the examiner through the cone with stained meniscus manifests the intraocular pressure. Okay, just see here that you are seeing some curves, right? Like this and like this. So that is what is very important here looks like. So see, this is the technique of Applanation Tonometer. The tonometer is actually here. Can you see? This part is that tonometer. They are looking through this. But anyways, guys, this is just mounted on a standard slit lamp. Okay, the Applanation Tonometer. This is the most popular one, Goldmann Tonometer. Okay, it's the accurate one. Here you will have a double prism which is mounted where on the standard slit lamp. Okay, they are giving you some exact cornea, etc. measurement. So you will anesthetize the eye with 2% xylocaine. Then you will stain the tear film with fluorescein. Okay, and then you will use cobalt blue light from the slit lamp. So you will advance the biprism till it touches the apex of cornea. Then you will see two fluorescent semicircles, which you saw, right? You saw two fluorescent semicircles in that cobalt blue light. If you see, how will it be like this? Some two semicircles you will see, right? You will adjust until the inner edge of the two semicircles just touch. You will adjust such that the inner edges of the two semicircles just touch. This is the end point. The intraocular pressure is determined by multiplying the dial reading with 10. So whatever reading it is showing, there's a dial here. Whichever reading it is showing into 10 you should do. That will give you the intraocular pressure. Focus, guys. So let's look at another photo here. They are showing something like a different kind of thing. There's a digital reading here. So this is how that semicircle looks like. Okay. So what is this showing you? Fluorescein stained Myers of the Applanation Tonometer. So what is the next one showing you? Okay, so this is the good one. This is perfect. You see how they are aligned, the semicircles. But this one is not aligned. Not aligned. Need to move tonoprism forward. This one is not aligned. You have to move the prism backward. See, it is actually kind of into each other. This is also not correct. This one is not into each other. They are not at all aligned. So this is not okay. Then what is this? Lines are too thin. So this is not acceptable. Lines are too thick. You will not be accepting this. So too thin, too thick, too thin, too thick, not acceptable. Not aligned, not aligned, not acceptable. This is perfect thickness and aligned. Okay. Did you get it, guys? Now coming to this one. Endpoint of tonometry. See this one, they're telling you it is A is too small, B is too large. This is the endpoint. This is perfect. Why are they saying this is so small? Shouldn't this be too thick or something? Guys, we're done with Goldmann tonometer. Now still what and all is left? Perkin's Applanation Tonometer, Pneumatic Tonometer, Pulsar Tonometer and Tono-Pen computerized pocket tonometer. Let's look at these. First, let's look at Perkin's. What do you say, people? Perkin's Applanation Tonometer, you can see it is a handheld tonometer using the same biprism as in Goldmann, same biprism, 2 prisms, double prism. It does not require slit lamp, so that is an advantage, right? And it is very easy to carry, it looks like. However, it requires considerable practice. So it requires lot of practice it requires, okay. So here they are showing some Perkin's Applanation, handheld Applanation. Yeah, same thing. Look at that circle and all that. Here you can see some, I think this is the biprism, that cone. Let's see this one also better, wait. Yeah, looks like, right? This part of it looks like that Goldmann. Yeah, so this is handheld, but it requires a lot of practice. Then you have the pneumatic tonometer, guys. So look at this, seems to be the pneumatic one. Just see what you think about it. You see this? The same thing that they are holding here, this white and black pen kind of thing, it's there here. See, they've kept it here. And this device is showing some reading and it's also printing. Nice, right? So this is some pneumatic tonometer. In this, the cornea is applanated by touching its apex via sialistic diaphragm. So they're using some sialistic diaphragm which is touching the apex. Sialistic diaphragm. Covering the sensing nozzle. There's some sensing nozzle that is covered by the diaphragm. That diaphragm is touching the cornea. Okay. Then there is a pneumatic to electronic transducer. That means air to electronic transducer. It converts the air pressure into a reading on the paper strip. Did it make any sense, guys? So there is a sensing nozzle on which there's some diaphragm that is touching your cornea. And then this air pressure is converted to electrical signal and this machine prints the IOP. So we will have some documentation. Pulsar Tonometer. Yeah, guys, just 2 more. Pulsar Tonometer, guys. I think this is the one they have used on me. I really don't like it. There will be air puff that will come and you feel like blinking, right? And that will measure the intraocular pressure. See, this Pulsar one is handheld, no contact. So you just need that air puff, right? So it's no contact. Remember, this is no contact. But even you will get a desktop version, no need to hold in hand, okay? Then coming to Tono-Pen, again, this is also touch only. In all this, whatever we saw, no contact is only this one, looks like, the Pulsar one. And this tonometer, Tono-Pen, this is computerized and it's pocket tonometer. Just keep it in your pocket and you can measure somebody's IOP. It converts IOP into electrical waves. It applanates the cornea. It will have some microscopic transducer and it will give some electric waves and it will display the IOP. 13. What do you think 13 is? Is it fine or not, guys? See, Tono-Pen. It's showing 13. 13 is nice, right? It's normal, right? What do you say, guys? Good. So we are done with all the Applanation tonometers also. So let's take a recap. Guys, in this video, we want to look at tonometry, which is nothing but measuring of the intraocular pressure. If intraocular pressure is there, high, then that person can go into glaucoma. So that's why they are checking this. So there is a lot of ways of checking your intraocular pressure. Subjective method is there using your fingers, and there is another way to do by using instruments. So when it comes to instruments, you have the Indentation Tonometer and the Applanation Tonometer. Indentation measures the depth, okay, by which you can indent, right, the cornea. Applanation is the force required for you to flatten the surface, which is proportional to your pressure inside the sphere. So you have for the indentation, you have the Schiotz Tonometer. For applanation, you have the Goldmann Tonometer, Perkin's Pneumatic Tonometer, Pulsar Tonometer, Tono-Pen. This Pulsar one is the no contact one. Okay, everything else has contact. What do you say, people? Right? So look at this one, subjective method. You will use the fingers. You will place 2 fingers at short distance from one another above the superior tarsal plate and you will check the fluctuation. This is a very subjective method. You need a lot of experience. And when it comes to indentation tonometer, the plunger will be there. It will indent the soft eye more than the hard eye. You have the Schiotz Tonometer. It's cheap. You don't need any current or any electronic transducer to convert anything. It will directly give you a reading based on how much it's plunging. So in this you have some weights. 5.5 is fixed and you can add 7.5 gram or 10 gram. Basically if the reading is coming low, that means intraocular pressure is high. So what you do is you add more weights. Okay, that's what they're saying. So in this case you'll have to give a local anesthetic like xylocaine 2%. And this is the scale by which you can measure. Okay, we have seen this. So basically you will anesthetize the cornea. First of all, you sterilize this tonometer, then you anesthetize the cornea with the 2% xylocaine. You make the patient sleep supine and then you measure it. You hold the lids and etc. we have told you already. And if the reading is less, then you should add some weights. Then there's a conversion table to give you the IOP, right? So basically Schiotz Tonometer is cheap, handy, etc. The disadvantage is that it can give false reading. If there is abnormal scleral rigidity in high myopes, it can happen. See, the normal IOP should be 10 to 21 millimeter of mercury. Okay, average around 16. So 10 to 21 millimeter of mercury is normal. Okay, so that normal at least you should know, right? Above 22, it will be raised intraocular pressure. So coming to Applanation Tonometry, this will measure the force that is required to flatten the cornea, which has pressure inside, right? Which has pressure inside. So that is what is the intraocular pressure. So simple, right? So here you have the force. So the pressure is equal to force by area. This is the Iimbert-Fick law. Iimbert-Fick law. Okay. Then coming to this, you actually mount this equipment on a normal slit lamp. You will have to first of all anesthetize the eye, then sterilize all this. Then you will adjust it such a way. This is also having biprism. Okay, so this is having prism. So here you can see this is the biprism and this is the cornea. You have some meniscus which is created by the tear film. Okay, and that meniscus will be something like this under the cobalt blue light we have seen, right? This one you should align in the inner parts of the semicircle. Then you will get the reading. Whatever reading you get, you have to multiply by 10. That's what they said, right? So they have mounted it on a slit lamp. It's the most popular accurate tonometer. It is the accurate tonometer. Remember Goldmann. And you'll use 2 prisms, right? Double prism it has. You'll anesthetize the eye with 2% xylocaine. You'll stain the tear film with fluorescein. You also need to stain the tear film in this case. Remember, then with cobalt blue light you will see. Then you will advance the biprism such that it touches the cornea. And then you will adjust such that the inner edges of the 2 semicircles just touch. Okay. So this is another thing which they are showing, how the meniscus is appearing, right? And this one is perfect. Here you can see they are not touching. Here they are like way too apart. This one is too thin. This one is too thick. Okay. So if they are too much inside, what you should do, you should go backward. If they are apart still, you have to go forward. Okay. As simple as that. That's what they told here also. Then Goldmann is over. Whatever reading you get, you have to multiply by 10. That did we tell you? That reading you have to multiply by 10. Yeah, multiplying the dial reading with 10. This is important. So where will you get the reading after matching the meniscus and all that? Okay guys, then we saw Perkin's Applanation Tonometer. This one basically is handheld. It also has this double prism, but it requires a lot of practice. Okay. Then coming to Pneumatic Tonometer, what did you see in this? It will have a sensing nozzle which will be covered with a sialistic diaphragm that is going to touch the cornea. Then the air pressure is going to convert it into electrical energy and it's going to print in a paper the intraocular pressure. Then you have the Pulsar Tonometer. This is, remember, this one is non-contact. You will get handheld version, even desktop version. Basically, this is not using contact. Okay. Then coming to Tono-Pen, this is computerized pocket tonometer. It will have microscopic transducer. Obviously, it is micro, small pocket one. It will convert the intraocular pressure into electric waves and it will give you a reading. So that's it guys. We have finished in this video Tonometry. Hope you have learned something. Bye bye. Guys, remember tonography is nothing to do with tonometry because it's nothing to do like a graph of tonometry, nothing. Tonography is actually measuring the aqueous outflow. It's a different concept, okay? Don't get confused. Tonography is about the outflow. But what we looked at is tonometry, measuring the intraocular pressure. Okay. Bye bye.